My dear participants, respected teachers, fellows, students, I welcome you everyone to our today's webinar. Our chairperson today is our beloved teacher, ex-president boss and director Network, Professor Shiratul Islam. And in the panel of experts, we have Professor Khandukalaur Rizvi, who was our dear teacher and was also ex-president boss and director Network. We all know these two teachers are the direct descendants, our ancestors, who started the orthopedic development in this country with like R.J. Das and his initial students. They are actually the direct descendants of them. So, and we have with us our overseas expert, Professor Raju Best, who is working at the Apollo Hospital, Delhi. He is our longtime friend, of course, and he provided facilities like training our young surgeons over there for years. And he has a long friendship with us still. And he is a renowned arthroplasty and arthroscopic surgeon. And we have in our expert panel Dr. M. Ali, who is Chief Consultant, the Department of Orthopedics of Wakil Hospital, Dhaka. He is the most leading and eminent knee surgeon of the country, I must say. And also, he was the pioneer in arthroscopic knee surgery in our country. He actually initially fought his way in complete arthroscopic care of the knee problems amongst all odds, and all our teachers helped him in fighting and establishing the arthroscopic treatment in our country, and also provided training to interested students within the limited facilities in those days. And our today's speaker is Dr. Wakil Ahmed. He is also a prominent knee surgeon of the country, and he is now associate professor of orthopedic surgery and head of the department of Shahid Tajuddin Medical College. I must say about Wakil that he was very much student friendly and having a very gentle attitude towards teachers, students, and his patients and all. In the beginning, I must mention that about the names of, and I must express deep condolence for those who succumbed to COVID-19, people like Professor Musharraf Hussain, who was our teacher, and Associate Professor Somil Islam Babu, and Nurul Islam Taslim from Chittagong, and also recently passed Dr. Rejanul Bari Shamim, who was our student and junior, and last night our Madam Ilaha died. So we mourn their death and pray to Almighty Allah so that they be granted Jannah. And now ask Wakil to present his case, the tuberculosis of the knee. Dr. Wakil Ahmed.
Thank you, sir. Thank you, Dr. Farkasham, for inviting me to present my paper. Respected chairperson of this webinar, my respected teacher, Professor Muhammad Shirazul Islam, panel of experts, my respected teacher, Professor Khandukalaur Rizvi, Professor and Senior Consultant of the Hospital of Delhi, Dr. Raju Best, Dr. Mustafa Ali, Senior Consultant and Chief Coordinator of Wakil Hospital, Department of Orthopedic Surgery. My other teachers, learned participants, my colleagues and friends, Assalamu alaikum and very, very good evening. I'd like to welcome to all of you to my presentation on tuberculosis of the knee joint. After my presentation, there will be interactive, participatory and multilateral discussion on some different questions from the participant also. So we are going to my presentation. Dear participants, please see this picture the tip of the iceberg, the weak sizes ice, but small portion is above the water level. The large portion is hidden under the water. So you think of this picture, and I'm going to present. Before my presentation, I want to show some global scenario of tuberculosis, which was published in 2018 by WHO. 1/4 of the world population is thought to have the latent tuberculosis. There is, you think, 1 person in every 4 is affected of the world population. New infection occurs in about 1% of the population of each year. That is, you think, in our country, 1.8 million people every year affected by tuberculosis. And it was 1.5 million. So it is the number 1 cause of death from infectious disease. Most of the tuberculosis detected in this region of Southeast Asia, about 44%. In Africa, 24%, and Western countries, there is 18%. And more than 50% of the cases is diagnosed in 8 countries like India, China, Indonesia, Philippines, Nigeria, and Bangladesh. And about 80% of the people of many African and Asian countries are tuberculosis test positive, while only 5 to 10% in the US populations. By the age of 40 to 50 years, almost 100% of the population of this country infected by tuberculosis. Do you know it? But only 10% patients have the symptom, and remaining 90% asymptomatic and latent tuberculosis. Why this tuberculosis is rising in the third world countries? Yes, it is due to HIV infection, you know. The HIV patients are in high risk for developing tuberculosis. The people who are living in the overcrowded area, in the slum, in the prisons, in the school, sometimes the health workers, the malnourished portion of the populations, intravenous drug abusers, smokers, alcoholics, diabetics, and finally, immunosuppressed peoples are in high risk group. And now the tuberculosis of the joint, our today's topic. You know the largest weight-bearing joint of the body, the knee, with the largest intra-articular space. The third common site for osteoarticular tuberculosis, next to spine and hip, and it accounts for about 10% of all the skeletal tuberculosis. So how the tubercular bacilli comes to the joint? You know it is hematogenous spread from the primary focus or lung or other site. It comes into the joint, into the synovium, into the subchondral bone or juxta-articular osseous area through the hematogenous dissemination. In the synovium, it produces synovitis. For many days, it remains, and then it causes the congestion of the synovium, edematous, and some started tubercles there. You see the picture on the left side, the pinkish color started the tubercle, the arthroscopic view of the tubercular arthritis of the knee joint. And if we cannot arrest the disease, if we cannot treat the case, there may be sequelae of some complications like the tubercular abscess, subchondral bone, in the epiphyseal bone, or in the metaphyseal region. You see the picture on the left side, the red arrow, it's a huge collection, cold abscess in the medial aspect of the knee joint. So, if the disease cannot be arrested initially, in the early stage, it passes through the different stages, you know. The stage 1 is the stage of synovitis. Stage 2, stage of early arthritis. Stage 3, stage of advanced arthritis. In the stage 1 and 2, there are minimum limitation of the movement, but in the advanced stage, there is limitation of the joint movement and function is impaired. In the advanced stage, you see advanced arthritis, there is subluxation or dislocation of the joints. And finally, if it is not arrested, there is ankylosis, there is fibrous ankylosis of the joint may occur. So, diagnosis of the tuberculosis of the knee joint or joints is not always easy, because joint tuberculosis doesn't have always the typical feature of tuberculosis. More than 50% of the cases don't present typically, but the patient who present may have sometimes the fatigue, lethargy, weight loss, pyrexia of unknown origin, and locally there is pain which increases at night. There may be stiffness, maybe limping or restriction of the movements, swelling, and rise of local temperature. But many of the patients may present only with the pain, which is intermittent, increases at night, and patient cannot sleep at night. The night cries. On examination, the joint length we find tender. The patellar tape may be present due to the collection of the fluid or effusion within the joint. So bogey or dull filling of the synovium, regional lymphadenopathy, and gross wasting of the muscles. In advanced stage, there may be the triple deformity of the knee joints. You see the picture, the triple deformity is the flexion of the joint, is the posterior lateral subluxation, and there is external rotation of the joint. It is typical findings of the advanced and complicated tuberculosis of the knee joint. But this feature can also be found in the rheumatoid arthritis, in iliotibial band contracture, post-polio deformity, and bleeding and clotting disorders. So, all these problems of the joints, we cannot solve. We don't have the remote control of the problem at the moment in a second. We have to detect, we have to investigate the case, we have to find out the cause, and then we should treat. You see, these are the investigations we can do for diagnosis of the tuberculosis of the joints. So, routine blood count you can do with CRP, tuberculosis skin test or Monpro test we can do, the X-ray of the affected joint, and at the same time X-ray of the chest, the MRI, synovial fluid culture, PCR, synovial biopsy. Mycobacterium tuberculosis can be directly detected by NAA, nucleic acid amplification test, by direct microscopy, fluorescent microscopy, gene exposure like this, and DST also we can do for susceptibility of the drugs in case of resistant variety. But the gold standard test for the tubercular arthritis is the synovial biopsy, which is 80% positive in cases. And the typical findings of the granuloma, the lymphocyte, the giant cell with caseation. So we have to find out and then to treat the case. But there are some patients having no typical feature, and in histologically or bacteriologically we don't find something, any confirmation. The problem with the patient, on the basis of histological and bacteriological status, we recommend the joint tuberculosis can be classified histologically or bacteriologically confirmed case and clinically diagnosed case. This clinically diagnosed group doesn't have the typical feature, doesn't have the histological or bacteriological confirmation. In the X-ray, what you see, there is a triad of radiological abnormalities. This triad is called the Femistas triad, and we can remember is by 3 P's. You see the peripheral periarticular osteoporosis. You see the peripheral osseous erosion. In the X-ray, you see there is a red mark, peripheral erosion in the femur and proximal tibia, and progressive or gradual diminution of the joint space. These are the triad of radiological abnormalities of a joint tuberculosis. But what is seen in the early stage? In the very early stage, there may be no change in the X-ray, or there is no change in the radiologically. Sometimes there may be the enlargement of the devices of the children, in case of children due to the hyperemia. And in early stage, we see the periarticular demineralization, widening of the joint space, and this is due to the collection of the fluid, synovial fluid, due to diffusion, and there may be some destruction. In the advanced stage, you see the gradual narrowing of the joint space. There is subchondral destruction. In a more advanced stage, there is subluxation and dislocation. And finally, there is ankylosis. You see some other X-ray and MRI feature. There are multiple lesions in the X-ray, multiple lesions in the MRI, the tuberculosis of the knee joint. You see the cross articular damage, and you see there is sequestration of the osteoarticular part of the joint due to the tuberculosis. And finally, the fate is the tubercular ankylosis, which is a fibrous ankylosis of the joint. Another one classical feature of the joint tuberculosis is the rice bodies. These are the small loose bodies within the joint we see produced by the synovium due to the disease process. Looks like the rice, granules of the rice, see in the MRI. You see the arthroscopic view. These are the typical views of the rice bodies. And if you do arthrotomy, you see like this. And this is a classic findings of tuberculosis. But sometimes we see these rice bodies in the rheumatoid arthritis, synovial chondromatosis, and some other conditions also. So the diagnosis of the tubercular infection of the bone and joints largely on suspicion sometimes. So a high index of suspicion is essential for diagnosis of the joint tuberculosis, especially the knee joint. All the clinicians should be aware of this. And joint tuberculosis may be suspected in a chronic joint pain when it is not responding to the conventional analgesics or conventional treatment, and when it is usually monoarticular. In that case, we should suspect it as a tuberculosis of the joint. And the biggest challenge is the diagnosis of the tuberculosis and its consideration of its possibility in the differential diagnosis. Sometimes the diagnosis of the tuberculosis arthritis is delayed because the lack of typical features of the tuberculosis absent. Sometimes there is lack of characteristics early radiological findings. The onset may be sometimes insidious, and the lack of awareness. Many of the people don't know the TB can occur in the TB can infect the joint, TB can infect the knee joint by other joints of the body. So the lack of awareness is another cause. So these are the differential diagnoses. See the monoarticular rheumatoid arthritis, juvenile chronic arthritis, and synovial chondromatosis. This may be the differential diagnosis of the knee joint. So what about the treatment? There are different options. The first line of the treatment or defense, the mainstay of the treatment is the combination chemotherapy, that is non-surgical. We can use combination chemotherapy if we detect it early and continue the drug. If the response is good, then continue for adequate time. If it doesn't respond, but if we suspect or we confirm the diagnosis, then we can do the debridement of the joint, either arthroscopically or by open debridement. Sometimes we can do the synovectomy. Sometimes we need to do the arthrodesis in right foot anterior flexion. Very rarely we need to do accommodation. And finally, we can do the knee joint replacement for tubercular arthritis when the joint is restricted, when the disease is advanced. So let's have a look to the anti-tubercular drugs. All of you know, just it's a reminder. The first line of drug is C, the INH, rifampicin, ethambutyl, pyrazinamide. The second line of drug, ethionamide, prothionamide, cycloserine, paraaminosalicylate acid. 4 quinolone derivatives, levofloxacin, moxifloxacin, ofloxacin. There are some injectable anti-tubercular drugs, the kanamycin, amikacin, caprimycin, and streptomycin. And the newer injectable anti-TB drugs now added, that is imipenem, meropenem, and amoxicillin clavulanate acid combination. These are the anti-tubercular drugs so far used nowadays, and for cure of the tuberculosis of the knee joint. But there are some principles we should follow for the treatment of the joint tuberculosis or any tuberculosis. It is the appropriate combination. So one drug cannot cure the tuberculosis, So appropriate combination is essential. Duration of the treatment is also essential. The required duration, if you treat the joint tuberculosis like pulmonary TB, 6 months to 9 months, the joint tuberculosis will not cure. So we need longer duration of treatment for joint tuberculosis and correct dose. Pediatric dose cannot cure the adult patient. So appropriate combination of the drug, required duration, and the correct dose. These are the principles we should follow for the tuberculosis of the joints. What we follow usually, the treatment usually in the primary cases, in newly detected cases, we follow the 4-drug regime. Initial 2 months. In the 4-drug, we use the INH, rifampicin, ethambutal, and pyrazinamide. For 2 months, then continuation phase, we usually use the 2-drug INH and rifampicin for 18 to 24 months. That is up to 2 years. But the problem is with the MDR TB, that is multi-drug resistant tuberculosis, and the XDR TB, that is extensive resistant tuberculosis. The MDR, what is MDR? MDR TB is the tuberculosis that doesn't respond at least 2 drugs, 2 important drug, INH and rifampicin. These are the most powerful anti-tubercular drug, but resistant to these 2 drugs, that is MDR TB. And what is XDR TB? XDR TB, there are rifampicin INH resistant plus one of the fluoroquinolone derivatives and one of the injectable anti-tubercular drugs. These are the extensive drug resistant tuberculosis. So for the treatment of MDR or XDR, the drugs, anti-tubercular drugs, are classified into 4 groups. Group A, fluoroquinolone derivatives, that is levofloxacin, moxifloxacin, gedifloxacin. Group B, injectable, that is amikacin, kanamycin, capomycin. Group C, ethionamide, prothionamide, cycloserine, like this. And group D, D is subdivided to D1, D2, D3. These are the drugs you see. So for treatment of this MDR, all the 4 groups should be included. MDR TB, you see, in initial intensive phase, combination of the 5 drug we should use, 5 drug. Among the 5 drug, PZ8, that is pyrazinamide, is fixed from group 4, you see, and 1 from group A, 1 from group B, and 2 from group C. You see the group again. From group B, pyrazinamide. From group A, 1 drug. From group B, 1 drug, injectable, and from group C, 2 drug. Total 5 drug. These 5 drug initial intensive combination therapy for usually for 8 months. By this time, 5 to 6 months, we should do the investigation whether it is converting to non-histological is negative, or confirmation is negative, or culture is negative. Then we will continue the drug for 2 years. If it is not responding or non-converting, then sometime injectable antibiotic can continue for 10 months. Or if it is responding, then continue up to 2 years. The problem is with extensive drug resistance tuberculosis. That is, if still with intensive therapy with the 5 drugs, there is no response, then we should do DST. That is, drug sensitivity or susceptibility test, and we should treat the extensive drug resistant tuberculosis according to DST report. So up to this, I talked about the joint tuberculosis, their causes, their features, and their treatment. Now I want to share some of my experience during my surgical practice of the knee joints. During the period of January 2017 to March 2020, I got 7 patients of tuberculosis of the knee joint. Male-female ratio was 4.3 and age range was 18 to 45 years. Only one patient had the family history of pulmonary tuberculosis, and no patient had concomitant pulmonary and joint tuberculosis. In 6 patients, we did arthroscopic procedure for ACL or meniscal procedure. After 3 to 4 weeks or 5 weeks, we see the patients have increased pain in the joint, and the pain is intermittent, pain is increasing, pain disturbs at night. Sometimes the patient cries, the whole family cannot sleep at night. They call me, call my assistant several times, even at 12 midnight, 1 p.m. the patient is crying. So what is the solution? We tried several times with many medications, many conventional analgesic and treatment, but the patient didn't improve. And in another one patient, we did diagnostic arthroscopy. We did annual biopsy. It was confirmed and treated. So all the 7 patients, so we did arthroscopy. After treatment, when we cannot improve the patients, then we did some investigations like MT again, CBC, VTSR, CXR, and X-ray of the knee joint fluid study, and synovial biopsy in one patient only. So we found MT test positive in only one patient with ESR 90. CS report, we found one patient in the Pseudomonas. Synovial biopsy, one positive, and in other patients we got nothing. But we didn't any PCR any of the patient. So in this case, on clinical suspicion, we started tuberculosis, anti-tubercular drug in 6 patients. And Pseudomonas patient we treated according to CS report. And dramatically, we see after 3 to 4 weeks, the patient was improving, except one female, she was not improved. And we continued the drug for 24 months. 5 patients improved. The one patient who didn't improve, she was treated later on out of the country. And so far I got the news from the relatives and the patient. She was MDR TB and treated in India. And finally, she was also cured. So for a healthy life, for a good life, we need a stable knee. We need a full range of motion and good functioning knee. And the takeaway for today is that TB is still an important global public health problem. The biggest challenge is in the diagnosis of the tubercular arthritis. A high index of suspicion is necessary, especially when it is persistent pain in the monoarthritis. Early diagnosis is essential to preserve the good articular function and joint space. Early, specific, and adequate treatment can maintain a good joint function. Negative culture, negative smear, negative MT test doesn't exclude the diagnosis of the tubercular arthritis. So bone and joint tuberculosis is more of a risk in developing countries. So let's work together to eliminate the tuberculosis from the world, from the country, and to say goodbye to tuberculosis. Thank you very much for hearing. Thank you very much for participating. And I have one question to the panel of experts and participants for open discussion. Combination chemotherapy, what we are using in clinically diagnosed joint tuberculosis, that is, the patient, we have no histological or bacteriological confirmation. We are using the anti-tubercular drug for 2 years. Maybe patient is improving. Is it justified or not? This is for open discussion of today's webinar. Thank you very much.
Thank you very much, Dr. Wakil, for your nice and elaborate description on a very good topic, which is very common in this region. I am now, as there are some questions, one or two maybe in the question box. So I would like to ask one of our experts, Dr. Emali, to discuss briefly on this presentation first.
Thank you, and forgive me the chance to say something in front of the giants, especially the foreign experts and my teachers, especially Professor Kunal Rizvi sir, Shazul Islam sir, Bari sir. So it's a very good and nice discussion, and it's a ever-ending problem of a developing country like us. Tuberculosis is very common, and now in the era of this COVID situation, it is neglected. But the disease is still into the society, and there is a lot of suffering people with this tubercular arthritis. It is relatively uncommon in musculoskeletal tuberculosis, especially in the knee, because it's more common in the spine and hip. It is a little more than ankle, but it is in the third position. A lot of patients come to us with this tubercular arthritis of the knee, with especially only featuring of pain in the knee, which has not been treated well or not responding by the medications. So on that situation, we try to solve the issue by having proper history taking, that it is a long-standing problem and it causes the wasting and of the thigh, and there is a gradual swelling of the knee, and especially the synovial thickening is much more prominent than any other cause of the knee pain. And the most important scientific sign is that is usually related with the contracture. Means fixed flexion deformity, especially in the range of minus 10-15 degree to 70-80 degree range of motion is always like this kind of things is always available. Means that it is responding more on the stiffness and fixed flexion deformity with synovitis and wasting and pain. And for that reasons, we try to investigate, and investigation is the tool that we can identify nowadays strongly and can confirm our diagnosis by the PCR test, synovial fluid analysis, and culture sensitivity test. Though the ESS, erectroprotein, and also the other test is not very sensitive, but the biopsy and PCR test is very sensitive, and it is the synovial culture that can give you the confirmatory diagnosis. Regarding the treatment options, we have missed one thing possibly that we can add on Dr. Wakil.
Yes.
That during the conservative treatment, we have to go for the physiotherapy and also kind of activity limitation, because there is articular distraction, and if you put more and more pressure on the damaged articular cartilage, the deformity and the degeneration is much more potentiated. So the supported walking and gradually increasing range of motion is advisable, and the thigh muscle, as it has been weak, so the quadricep muscle and range of motion exercises is to be established from the beginning of the mediation. Regarding the surgical treatment,
there are some number of questions.
Please.
I will again come to you. So there's one question from Mohammad Musa. Is TB knee associated with pulmonary tuberculosis? Dr. Wakil, could you answer the question?
Is TB knee?
Is TB knee associated with pulmonary tuberculosis?
Yes, around approximately 50% of the cases may be associated. Sometimes may be associated, but I didn't find any case in my series is associated with the tuberculosis. Only one patient I found that family history of tuberculosis.
Thanks, Dr. Wakil. I would like to ask our teacher, Professor Rizvi, to comment about this, the association between pulmonary tuberculosis and TB knee.
Okay, thank you, Farooq Kasem. We know TB is a very common disease in our part of the world, and in fact, almost most of the people some way being infected by TB. Okay, we call it TB in quiescent state. And we know this osteoarticular tuberculosis is always secondary. So, secondary. Osteoarticular tuberculosis secondary. Infection route is either the lung or GI tract. Mycobacterium tuberculosis is mostly is airborne and mostly primary is in the lung. Then it goes to the other part of the body. Okay, in the joints, okay, in the bones, okay, in the other parts. And of this osteoarticular tuberculosis, most commonly it affects the spine. Okay, then the large joint, load-bearing joints, hip and knee. Knee in that respect is third in position. So the questioner asked whether there is any association of pulmonary tuberculosis with the knee TB. In some way has to be linked up, because primary lesion always in the lung. Okay, so it remain in the lung in quiescent stage. When opportunity is there, especially in the joints, so when there is some injury to the joints, or we do some surgeries, we injure the joint. So when there is hematoma formation in the joint or inflammation in the bone, then if the patient is in that moment is immunocompromised, okay, so there is chance of activation of this because of there is a bacteremia in the body. So the bacteremia, bacillus can travel to that mostly via the blood and lymphatics, go to the joints, okay, and may cause tuberculosis of this particular area.
Thank you, sir. I would like to ask one question to our overseas expert, Dr. Raju Bose. After completion of it is from Dr. Anand. After completion of TB treatment, is there any indication of total knee arthroplasty? Dr. Raju, please.
Yes, I mean, tuberculosis is one of the infection which is low grade, although persistent type, in which joint replacement can be done. Ideally, the disease should be under control or healed when you consider knee replacement. But many times you have inflammatory arthritis and you have suspected other disease like rheumatoid arthritis or synovial chondromatosis, and then you do a knee replacement and the biopsy comes as tuberculosis. But still I have seen a lot of patients who have had successful joint replacement without activation of infection in the joint. So it is possible to do joint replacement after tubercular infection. Ideally, it should be done when the disease has healed or is well under control.
Thank you. Thank you, Raju.
May I continue?
Sure.
Can I ask a question related to this issue?
Please.
Okay. If it is diagnosed as tuberculosis of the knee joint, okay, and we want to do a knee replacement surgery, okay, and you have started anti-tubercular drug, at what moment, at what point you can do this replacement?
Actually, there are many school of thoughts. Some people are doing it in active cases also.
Yes.
Right? Some people are doing it after 1 month. Some people are doing it after 3 months, 6 months, or after complete healing. And everybody claims good success. So I suppose there is some truth in it, but to be on the safer side, better to do it if you are not in rush when the disease is fully healed.
That means in terms of the duration of the treatment, when do you consider the disease has healed?
You see, normally we give the treatment for 9 to 12 months, and in all tubercular bony infections, I do obviously inflammatory markers, check the symptoms, and also I do the MRI at the end. If the bone marrow edema and other things have almost disappeared, then I consider the disease to be healed. Although the disease might have healed earlier than the disappearance of bone marrow edema, but it gives you a fair confidence to stop the anti-tubercular drugs.
Okay, thank you.
Thank you. Thank you.
So regarding the joint replacement in total in tuberculosis, I have a series of cases where I did the TKR in post tubercular arthritic patient. So the consideration is that we usually confirm the diagnosis and identified that this is a end-stage osteoarthritis, secondary osteoarthritis due to tuberculosis, with gross fixed flexion deformity, with kind of subluxation, lateral subluxation, and the triple deformity of the case. This kind of patients, we usually need surgery after 4 to 6 months of initial starting of the anti-tubercular drug. And it is especially important to balance the knee in such a way because the synovial tissues, tumors, the capsule and the ligaments all become contracted. So there is a very bad fixed flexion deformities, and it needs a lot of extensive release during the and soft tissue balance during the joint replacement. We have a group of people where we did the total knee replacement. Because of the suspicion, we did the spontaneous biopsy of every cases. Of 50 cases, we have diagnosed. We have sent the biopsy from our paraoperative patients for biopsy, and we found that 4 to 6% of the patient are suffering from tuberculosis, which we initially identified as a case of osteoarthritis. And regarding the other issues where we do the surgery in case of the tuberculosis, Wakil made a statement that the time of arthrotomy for this kind of synovial resection is the late, but we usually go for the early synovial resection in case of the resistant tuberculosis. Especially, we can do it also by the arthroscopic technique. And we also need to go for the surgeries in case of the discharging sinuses. And for criticizing Dr. Wakil that he did the surgeries and then he identified there is tuberculosis, means that there is something wrong before making the decision of going for surgery. So we have to be more meticulous of identifying the pathology, and then we have to go for surgery.
Thank you, Dr. Ali. Thank you.
Can I just add one more remark regarding knee replacement?
Go ahead.
One has to be very, very meticulous and careful if planning a knee replacement in tuberculosis because there may be severe deformity like triple deformity,
right.
There may be severe osteoporosis, or there may be severe stiffness with almost absent movement. In these cases, you must be prepared to use more constrained knee with long stems. Otherwise, your conventional knee will fail within no time. So one has to be very careful in planning these cases. These are not simple cases.
Thanks, Raju. And may I comment on this that I found in the literature then whether the disease is healed or not, but they always start anti-tubercular chemotherapy prior to surgery. Is that true? In a tubercular knee, whether it is healed or not. But if you do TKR, then you have to start the anti-tubercular therapy again. Is that, Raju?
The question, I missed it.
The question is, what I saw in the literature that many authors tell that if the disease is healed or active, they are doing in both the scenario, the total knee arthroplasty, but they always start anti-tubercular chemotherapy after surgery.
Oh yes, I mean, because there is always fear of reactivation of
right.
It is wise to continue anti-tubercular therapy post-operatively in a known case of TB.
Thank you. And we have another question from Dr. Khaled. It's a question plus a comment. Is clinically can diagnose joint tuberculosis? So I think no combination chemotherapy just after clinical suspicion. So you have to investigate, then start empirical treatment. Dr. Wakil, please comment on this.
One thing I want to mention, I invited one of the senior professor of medicine of Wakil Medical College, Professor Sheikh Abdul Fattah. Probably he is connected with us.
Oh, welcome, sir.
I welcome to Professor Sheikh Abdul Fattah, and I like to give a comment on. I already put this question to the panel of experts and the participants for open discussion on clinical suspicion or on clinical basis without any histological or bacteriological confirmation. We are using the anti-tubercular therapy for a long time. Is it justified or not? Please comment, Professor Sheikh Abdul Fattah, sir. Professor Sheikh Abdul Fattah, can you hear me, please, sir?
Assalamu alaikum.
Walaikum salam.
Assalamu alaikum. I am Professor Sheikh Abdul Fattah, respected senior teachers and orthopedicians of our country, and Dr. Wakil for inviting me in this session. There are two questions, important questions. One is whether it is reasonable to start anti-tuberculosis drug on clinical suspicion only. Another question is duration of treatment as orthopedicians use for 18 to 24 months, whether there is any reference or not. These are the two questions. First thing, in many extrapulmonary tuberculosis, it is sometimes difficult to get histological or bacteriological confirmation. But with clinical suspicion and other hematological features or PCR diagnosis are possible, if other relevant differential diagnosis can be excluded, we can start our anti-tuberculosis therapy without histological and bacteriological confirmation even. But it is better if possible to confirm it by any other method. And again, histological diagnosis of granulomatous inflammation is not actually confirmatory to tuberculosis. If AFB can be seen, only in that case you can say it is confirmed. Otherwise, histological diagnosis is also suggestive of tuberculosis. In summary, in many cases, without histological and microbiological confirmation on clinical ground only, we have to start anti-tuberculosis therapy in that case. Regarding second questions, I think the question arises as there is a guideline, national and international guideline, with category 1 therapy and category 2 therapy with specific duration of 6 months and 8 months. Possibly that is the reason why the confusion regarding duration of treatment arises. But we must remember that this guideline is prepared to use at the field level in a uniform basis only, not to guide the treatment by the specialist. The specialist should plan regarding duration of treatment, especially according to their own experience. And there are few data, research papers, published papers regarding duration, and according to most of the papers, study shows that it requires longer duration for cure of bone tuberculosis, especially the knee joint tuberculosis. As our senior orthopedician teachers are there, they will also agree definitely that in bone tuberculosis, longer duration of treatment is necessary.
Thank you, sir, for
no guideline is for no consensus is there regarding treatment of the duration of treatment of any joint tuberculosis. Thank you. Thank you.
Thank you, sir, for your nice and valuable comments. I don't see any more questions, but I have a question to the expert panel, especially to Alifai and Rizvi sir and Shah Islam sir, that what I saw in the literature that in the type 1 and type 2 cases, that is the early cases, there is chemical debridement has got a good role. And when we do, but what we saw in our practice for the years that if there is a TB knee, we have to go for surgical debridement, that is synovectomy, but which is never complete. And what is it? I found in the literature that it shows that for surgical debridement cases, those give more stiffness and rigidity. But those cases with chemical debridement, they give very, very good results and near complete motion of the knee. Would you comment, sir?
May I say something?
Sure, sir. You are the chairperson.
For the question. And I think all of us are almost familiar with the tuberculosis, and especially the tuberculosis of the knee, because as Wakil said, that knee is the most large synovial joint as well as the weight-bearing joint. That's why it is very important for the patient, especially in the village and those who are deliverer or they are to work hard for their survival. The one thing I like to say, and surgical procedure and non-surgical procedure is try to treat the patient non-surgically, without surgery. Because if a patient is gone through the surgical procedure, those patients, they have sometimes they are it is very difficult for them to come to the or come to unnecessarily for the surgery. And if we do the synovectomy, I think better if we can diagnose earlier, better we go for oral treatment of the tuberculosis. And it is better to treat the tuberculosis as you can do the treatment to assess the duration of the treatment by the doctor himself. And I think 1 or 2 months.
Hello?
I think
নেটওয়ার্কের মধ্যে একটু সমস্যা আছে।
So আমি একটু ডিসকাশন এগিয়ে নেই স্যার আসা পর্যন্ত।
হ্যাঁ প্লিজ ওই কোশ্চেনটা যেটা
আমি একটা গল্প বলি। একটা রোগী আমার কাছে এসেছিল, সে ডিসচার্জিং সাইনাস নিয়ে আমার কাছে এসেছিল। পরবর্তীতে আমরা সাইনোভিয়াল বায়োপসি, ওখান থেকে বায়োপসি নিয়ে দেখলাম যে the track is a tubercular track. এর আগের আমি যে সমস্ত ইনভেস্টিগেশন দেখলাম, অপারেশনের আগে এসিএল সার্জারি হয়েছিল পেশেন্টের। এই পেশেন্টের এমআরআই তে এসিএল ইনট্যাক্ট, অথচ সার্জারি হয়েছে। পেন আছে, পেনের অপারেশনের পরেও পেন আছে, এবং পরবর্তীতে ডিসচার্জিং সাইনাস শুরু হয়েছে। সেই সাইনাস স্ট্রাকচার
গ্রাফটা কোন
না, গ্রাফ তো হ্যাঁ
ইনট্যাক্ট এসিএল
প্রিভিয়াস এমআরআই তে এসিএল ইনট্যাক্ট।
ও আচ্ছা।
পরবর্তীতে সেই
বিফোর সার্জারি
পরবর্তীতে অপারেশন হয়েছে ওই রোগীর, এবং পরবর্তীতে ডিসচার্জিং সাইনাস নিয়ে এসছে। এর মানে হলো যে টোটাল সিস্টেমের ভিতরেই দেখেন ইনভেস্টিগেশন ডিফেক্টিভ ছিল, অ্যাসেসমেন্ট ডিফেক্টিভ ছিল, পোস্ট অপারেটিভ ট্রিটমেন্টও ডিফিকাল্ট ছিল। সুতরাং আমাদের এই পুরো জিনিসটাকে আবার ওভারঅলিং করা দরকার।
মানে ওটা যে টিবি ওটা জানতেই পারেনি, পরে ডিসচার্জিং
রাইট
in most of the cases যে আমি দেখছি which I have seen that if it is written in the MRI or it is said in the MRI that ACL is not seen, first sometimes we say that there is injury to the ACL, you will have to go for ACL reconstruction. That is sometimes very important, and the surgeons who do the surgery, they must evaluate the patient very well, because tuberculosis, as Raju Bush has said, that it is a granulomatous infection. It grows gradually, and if you not go through the patient through the joint very carefully, you will lose the signs. And patient, they usually come from the different places. The symptoms which we want to know from the patient according to the book which is written, sometimes in most of the cases we don't get it. So you will have to examine the patient very thoroughly, and especially the part of the examination. I want to say one thing from our Professor Gast, then examine. And without examination, if you do anything, you will be in trouble. আমি একটা গল্প বলি, যে এসে বললো, আলী গল্প বললো, আমি আর জানি আমাদের কেস, আমাদের এই ব্যাপার, কোন এক সিনিয়র সার্জন বলছে যে না, এই অপারেশন এটা আমি করবো না, আমাকে যত টাকাই দাও বা যত যাই করো, বাইরে যদিও প্রাইভেট প্র্যাকটিস, আমি অপারেশন করবো না। তারপরে অন্য এক সার্জন, জুনিয়র সার্জন, সে মনে করে এই সিম্পল কেসটা সার করতে যাচ্ছে না, আচ্ছা ঠিক আছে আমি করে দিই। তারপরে সে হাইসে পরে বলছে অপারেশন করে দিচ্ছে ঠিকই, পরে অবশ্য আমি যে তার জানাজা পড়ে দিয়ে আসছি, পরে আমি টুপি মাথায় দিয়ে তার বাড়িতে যেয়ে জানাজা পড়ে দিয়ে আসছি। এরকম ব্যবহার কি? এটা অনেকে আমরা জানি যে কার কথা বা কিভাবে করছে সেটা কথা না, আমরা এরকম ভুল করে থাকি যে কিছু না মনে করে সিনিয়র সার্জনরা বলতেছে না এটা করা দরকার নাই, কিন্তু জুনিয়র সার্জন আমরা অনেক সময় দেখা যায় যে আমরা মনে করি না এটা কোনো ব্যাপার না, ওই যে আলী যেটা বললো হয়তো ACL ইনট্যাক্ট রয়ে গেছে, আমরা অপারেশন করে দিচ্ছি। এইরকম ভুল যেন আমাদের না হয়, এটা আমাদের খুব চিন্তা করতে হবে। Very slowly growing, especially in case of মানে other than the lungs এটা হয়তো 6 মাস 1 মাস 2 মাস পরে এটা ডিটেক্ট করা যায়, বাট in the other cases, ওয়াকিল যে এতটুকু কথা আমাদের বললো, এখানে পেরিয়ার্টিকুলার অস্টিওপোরোসিস, পেরিয়ার্টিকুলার ইরোশন, এটা সেটা মানে এগুলো ইজ ভেরি ডিফিকাল্ট টু সি ইন দি এক্সরে, এবং আমাদের সময়ও অত আমরা দিতে পারি না যে যারা এক্সরে আছেন তারা কিন্তু, যারা এক্সরে করেন তারা কিন্তু মানে এক্সট্রা আর্টিকুলার মানে আর্টিকুলার মানে কোন এক্সরেতে তাদের রিপোর্ট কিন্তু সব সময় খুব মানে সুন্দর যে হয় এটা আমরা বলতে পারি না। কাজে আমাদের নিজেদের ভালো করে দেখাও,
নিজেদেরই দেখতে হবে ভালো করে,
আমাদেরই ডিসিশন নেওয়া উচিত। আর নন আর্টিকুলার থাকাটা, নন অপারেটিভ থাকতে পারে খুব।
Sir, we have a question. Another question, sir, from Dr. Mohammad Musa. I would like to pass the question to our Professor Rizvi, sir. Indication of synobectomy in TB knee.
Okay, thank you very much. Before I answer to that question, I want to talk on a few issues because I think following the discussion, there are some important issues need to be addressed.
Yes, sir.
Okay. One issue is that osteoarticular tuberculosis do not have past symptoms, signs, symptoms, or so diagnosis of tuberculosis is very, very difficult.
Yes.
Another problem of the osteoarticular tuberculosis is many of these osteoarticular tuberculosis is in inaccessible areas. Okay. So getting the sample tissues are very difficult, but this is not that difficult in case of the knee joint or the peripheral joint. Okay. in the past, we used to depend on the serological test or this skin test. This test has gone. All of this test is no more being given value nowadays. Okay, in endemic countries, MT test has no value unless the baby is very small, within 1 to 3 years of age. So there is no value of this MT test. Still, we do MT test. Okay, we sometimes depend on the blood picture. In fact, in articular tuberculosis, mostly blood pictures remains same. There is no change. Even ESR may rise up to 20, 40, 30 days. So the diagnosis may be difficult, but nowadays we have a lot of newer modalities of diagnostic methods. Yes. Then, as for example, we have molecular test. Now we have gene expert test. Gene expert plus or ultra gene expert ultra test. Ultra. These tests can give us a diagnosis up to 97% with accuracy sensitivity. But the problem in our country is that we don't have that much facilities everywhere. Okay, we have only 120 centers where you can do some kind of molecular test. Okay, so in our country we have much difficulty in diagnosing. So there is another question by Wakil. Do you treat this patient? It's very difficult. The answer is very difficult. Scientifically, or one should not agree to anti-tuberculosis treatment without the diagnosis. Give some form of diagnosis, either histological diagnosis or molecular diagnosis. Yes. Okay. Even sometimes seeing AB bacillus is not enough evidence to suggest that is tuberculosis, because we know there are so many types of microbacterium. Okay, so there is big issues. But I would rather follow, diagnose it, and then go for the treatment. Treating tuberculosis is difficult. Some of our senior surgeons have already mentioned that if the tuberculosis is diagnosed in the knee joint, okay, if it is in the early stage, you can treat non-surgical. Okay, but the question was when you do synovectomy. Okay, there was another discussion. Somebody mentioned that following synovectomy, the knee has a tendency to become stiff. Yes. So this is true. But with the knee joint, the advantage is we have now arthroscopy. Arthroscopy has manifold advantages. One is with the arthroscopy, you can see inside the joint. We can assess the joint. Okay, you can take the biopsy. You can take the biopsy. You can take the soluble fluid for this culture, for the serological test or molecular test. These can help you in diagnosis. And also, if you do a synovectomy, you can do synovectomy with arthroscope as well. Yes. And if you can do synovectomy with arthroscopy in the early stage, when this joint there is no distraction. If there is any distraction of the joints, synovectomy alone will not help. Then you will have to do a total clearance. You have to remove so many dead and necrotic tissues. By doing surgery, one advantage is that you can reduce the burden of this bacteria. You can reduce the burden of the necrotic tissue, which actually prevents in medical treatment. And also with this so many granulation tissue inside, when that because of this medicine, which granulation tissue is healed with fibrosis. That invites ankylosis of the joint. So surgery has certain values, especially if you want to do the synovectomy. I would prefer doing synovectomy in the early stage when synovium is only affected, and the reason for twofold reason. One important reason is to get the diagnosis, and two is to reduce the burden of this bacteria.
In the advanced cases, sir.
Yes.
Yeah. Thank you, sir. Thank you for your valuable comments. So we are nearly the end. So I have one last query to Ali Bhai. That I read in the literature that initially, and saw our senior teachers also, that when treating a knee with a TB, and they used to debride the joint and also debride the subchondral abscesses, or there is erosion, those are also curated. But later it was saw that there are possible bony parts, and if it is a child, there is always chance of growth arrest in that particular site. Do you comment on Ali Bhai?
Very difficult question, because debridement in tubercular arthritis is usually we prefer in case of the late stage, when we do not go for any kind of specific surgical treatment like arthrodesis, like joint replacement, or any kind of definite treatment, but still there is a little bit of motion is there, and there is a chance of preservation of some of the function of the knee by debridement in terms of deloading of the contents of the granulation tissues and the load of the bacteria. And at the same time, if we found that yes, subchondral cystic degeneration and the cavitation and a lot of granulation tissue formation, which cannot be treated by the penetration of the anti-tubercular medications. So at that time, we can go for debridement, and the remaining cartilage would be good enough for kind of further residual function of the joints, so that the patient can survive, sustain with this kind of joints. So means that what I like to say that we do limited debridement in case of the surgical cases where we do not go for any different surgery, but still there is some function can be reserved by the debridement, and this situation we usually go for the debridement.
Thank you.
But we more focus on the medical treatment rather than the surgical treatment.
Yes, that is chemical debridement. Thank you. And I think we are at the end. So I'd like to ask Professor Shirajul Islam sir, our chairperson, to say something before we conclude.
I want to notice one thing, that hematological test is not very important in diagnosis of the tuberculosis, but it should be very much important in our country, especially in our country, in the to see the improvement of the disease. So ESR 40 or 30 or 90, it is not important, but when it is gradually decreasing by your treatment, then we can say that it is gradually improving.
Yes, sir.
This should be
progress.
Progress. It is very important in case of progress. So I want to thank Dr. Wakil to arrange such a very good session, from which I can learn from our learned colleagues very much. That is very important, and especially in these cases, in these days where we are almost confined in our houses, then it is very important to see all the known faces after very long time, I should say. And Dr. Rizvi, probably he is also in very good health, and I am also, by the grace of the Allah, we are in good health. Thank you very much. And another thing I want to say, that Almighty Allah has given us a strong knowledge to the human being. The more you explore, the more you will get. So the treatment of, though it is another type of work, though if we do the practice as well as if we do this type of sessions and we compare the treatment to different parts of the area. We will someday will come when we can treat these cases very well. The TB almost gone from the world. Still, it is there, but we are encouraging. We are improving our knowledge to get rid of these things, and this is the spirit of the human being given by the Allah. The thing what I want to say, I thank to Raju Bose from India. He has joined us, and I have heard from him very encouraging thing about the tuberculosis, and I thank all the participants here. And we are now, though we are now a senior, and we have very limited time and limited energy to read, but we have to read. We have to read, and we have to treat the patient in proper way. And when I am not able to diagnose a patient, I should refer the patient to the other senior persons or those who can appropriate person. Yes, appropriate person. It should be very much in our mind. And thank you all. Thank you everybody, including Wakil Bari sir. Assalamu alaikum. I'm saying very late. You are muted, na? That's why you cannot hear from him. Thank you very much. Thank you.
Thank you, sir. Thank you very much for
Walaikum assalam. Walaikum assalam. Assalamu alaikum assalam.
Assalamualaikum, sir.
Thank you, everyone. Thank you for joining. We could share our knowledge and see and hear from our experts, our teachers, and all the dignitaries here. Professor Bari sir.
Thank you.
Thank you, Qasim. Thank you very much.
Thank you, sir.
Thank you, sir.
Very good to This is unofficial now.
Unofficial.